The etiology is either it can be a direct intravascular injection or rapid absorption from a richly vascular site. This is the common mistake that happens. What is negative aspiration toxicity?
Sir, as maybe the vein collapse, sir.
The vein may collapse and you may not get blood when you aspirate with a force, negative force. But once you push, there is a positive pressure which opens the vein, and the drug may totally go into the venous of the getting deposited around the nerve. That is the commonest reason. Otherwise, usually when you aspirate blood, you normally withdraw the needle and then try to relocate the needle before you inject. That mistake we will not make. But rarely the cause for this intravascular injection is the negative aspiration overdose or vascular injection. And patients who have comorbidities like hepatic dysfunction, cardiac disease, in pregnant patients, they all have chances of getting a local anesthetic toxicity even with a normal calculated body dosage. And extremes of age is another reason for that. And infants, because they have a low level of acid glycoprotein, which will be binding to the local anesthetic, is not there. So in infants, when you use lay drugs, you must be very, very careful. The pathophysiology inhibits the main components of oxidative phosphorylation pathway. And there are two main organs which cannot withstand anaerobic metabolism for a long time are the heart and brain, as all of you know. And these two organs are very much affected in pathophysiology of the local anesthetic systemic toxicity. And the cardiac toxicity is an important component of the last. And the local anesthetic bind and inhibit the voltage gated sodium channels from the cytosolic side of the sodium channel, not from the exterior, but they enter the inside of the cell, and then from the cytosolic side they block the voltage gated sodium channel, and this leads to conduction disturbances, contractile dysfunction, and with arrhythmias. And CNS toxicity is the next important thing. It is usually because one theory given for that is the there is a channel called quick related acid sensitive potassium channel, also called the TASP in short form. Quick related acid sensitive potassium channels, and these pH sensitive channels generate neuronal potassium leak current, and this will, the local anesthetic inhibition causes membrane depolarization and the neurons become more excitable. That is the reason why they start getting irritable, initially producing very mild effects like perioral numbness, tinnitus, and all those things, and then finally going to produce the seizure activity. And what is the difference between bupivacaine and lignocaine action on the myocytes? Did you mention about this, Sivatano?
Sir, bupivacaine is fastly blocks the sodium channel, sir, and it's slow out. It's a slow out fashion, sir.
Fast in and slow out, whereas lignocaine is fast in and fast out.
Fast out, sir.
So that is a very quick action on sodium channels, but very slow to get released from that. So that's called fast in slow fashion. Lignocaine causes a both fast in and fast out principle, meaning releases the sodium channel is much more faster, and that is the reason why lignocaine does not cause that much of prolonged effect even in the toxic doses, and recovery is much more faster. So the use of intralipid came into clinical practice mainly to revive the patients from bupivacaine toxicity rather than lignocaine toxicity, because bupivacaine has a longer duration of affinity for the sodium channel. And what are the initial signs and symptoms? It can be central nervous system toxicity followed by cardiovascular system toxicity, but very rarely, whenever the drug is frankly given intravenous or intravascular, cardiac toxicity may also be precipitated first. But generally speaking, central nervous system toxicity will be the first one to happen, like your patient are complaining of perioral numbness, tinnitus, getting restless, agitated, all these behavior changes will be there, followed by the seizure activity. So central nervous system toxicity is a two-stage process. Initial excitatory state followed by a depressive phase, and the early milder neurological features are perioral tingling, tinnitus, and slurred speech. That is the reason why whenever you do any major blocks like interscalene or supraclavicular block or an epidural block, it is always advisable to keep talking to the patient, asking them whether you are okay, are you feeling any difference in the sensation in the limb, do you feel any hot flushes, like that. You keep talking to the patient so that you can find out his mental state, whether it is all right or not. And the earliest sign of a slurred speech or not responding to your conversation properly, you have to know that you are going in for LAST. And the loss can occur without these characteristic premonitory signs also if you directly inject intravenous at a fast rate, and the excitatory neurological phase results in generalized convulsions. And this after the convulsion, patient will go into a depressive phase with coma and respiratory depression. The cardiovascular system toxicity happens classically in three phases. The first phase is hypertension and tachycardia. So always attach the monitors whenever you are doing a block, and keep a watch on the heart rate and the blood pressure of the patient and the SpO2 signal sound. So that is a very, very common thing when you are concentrating on injection site with and looking for aspiration of blood and other things. Keep your ears open to see whether the patient's heart rate and the monitor count goes up. That means you are either intravascular or the adrenaline, the drug is slightly aspirated into the vessels, something can happen. So always keep your eyes and ears open to the monitor to find out the first phase where you can immediately stop and prevent the last occurring. Then the intermediate phase is associated with myocardial depression, and that stage patient will go in for hypotension. And the final third phase includes peripheral vasodilatation, severe hypotension, variety of arrhythmias, usually bradycardia. So first phase you will have tachycardia. In the third phase you will have bradycardia and conduction block and ventricular tachyarrhythmias. And finally arrest also will happen. So earlier local anesthetic literature suggested that usually cardiac toxicity occurred after CNS toxicity. That is the generally documented evidence was like that. But if the drug is very potent, like your bupivacaine, or it is directly injected intravenously, then cardiac toxicity can arise concurrently or even earlier than the neurotoxicity or CNS toxicity. So don't always be thinking that first you will get all the milder symptoms of CNS irritation, then seizure, then only cardiac. Don't imagine like that. Rarely, in unfortunate timings, you can get a cardiac toxicity also as a first one. Then the Any test for evaluation of this local anesthetic overdosage? There is absolutely no test like that. But I have asked another question there. Is there an exception to any local anesthetic drug where you can find out whether it has happened as a toxic dose? With Anu.
Yes,
Do we have any of the, not a very commonly used drug, but it is available
sir.
to us in one form as a cream.
Okay.
Giving you
Okay,
the
sir.
proof.
Okay, sir.
That drug will produce a blood level of some marker as an excessive dosage. What is that drug? Local anesthetic. Prilocaine, fantastic, excellent. No tests are needed for other drugs, but prilocaine toxicity results in blood hemoglobinemia that can be identified by co-oximetry or spectrometry. Okay? So that will produce blood hemoglobin. That is also part of local anesthetic systemic toxicity. So that also you have to remember. And what is the treatment or management? First is ABC, airway. Here it is airway, breathing, circulation, not assessment of blood consumption as I showed in the earlier slide. And the three pillars of last treatment are seizure management, advanced cardiac life support, the administration of 20% lipid especially for bupivacaine toxicity. And for seizure management, you can use midazolam, which is very easily available and very effective also. Propofol and thiopentone can be used, but it has to be used with caution if a patient has already gone into the second or third stage of cardiotoxicity, where the patient will be severely hypotensive. So it has to be used with care, and so that is where caution to be exercised when using in patients with hypotension. And if these medications are unable to control seizures, small doses of succinylcholine also can be given, because patients have already lost consciousness, and you can use succinylcholine, which will be peripherally acting, which will at least prevent the neuromuscular transmission at the periphery and stop the seizure. But you must make sure that airway is taken care and ventilation is taken care. Okay, so that is one of the treatment. I think you didn't mention this, isn't it, in your answer? Did you mention it, Yutano?
Yes, sir. I mentioned.
Okay, right. And standard ACLS guidelines should be recommended, and small doses of heparin can be given. Vasopressin should be avoided because of pulmonary hemorrhage complication. And for treating ventricular arrhythmias, the preferred drug is amiodarone, and not any local anesthetic like propionamide. And lipid emulsion is commenced as early as possible. Now, mechanism, of course, he explained it. Works as a lipid sink, draws out the local anesthetic from its attachment to the sodium channels, and the starting dose is 1.5 ml of 20% emulsion per kg as a bolus over a period of 5 minutes time. Then you give the infusion after that at 0.25 ml per kg per minute, or multiplied by 60, and you can give 15 ml per kg per hour also. So whichever way you want to remember, it's okay. And if there is no response to the initial dose, you can again repeat the bolus and also increase the infusion dose. So, but the maximum you have to keep only 12 ml per kg. And if all these measures fail, then you have to think of going in for cardiopulmonary bypass till the local anesthetic is cleared by the body. The differential diagnosis of LAST sometimes patient anxiety, anaphylaxis, or illicit drug toxicity. These three things may mimic the LAST even when the drug is not gone into that. So unnecessarily you should not give lipid emulsion. These conditions of differential diagnosis. And the speed of absorption is a common question they ask you in the Viva. IV is the fastest, then tracheal, then intercostal, caudal epidural, lumbar epidural, then brachial plexus. So depending upon the vascular nature, and tumescent is the least. Why tumescent causes, even though you are using a large volume? What is the reason for the tumescent not causing they use almost 33 milligrams per kg of lignocaine in the chemical solution. But still,
But concentration, sir.
because of the adrenaline that is added, causes a severe vasoconstriction where absorption is prevented for quite some time. And the prevention of loss, prevention are modified by proper patient selection, choosing the right dose drug, repeated aspiration to rule out vascular injection while you are doing it, and injecting in small aliquots. That is, every 5 ml you aspirate, stop, and then inject. Repeated conversation with the patient while injecting the drug. Complete monitoring using during the procedure, and using ultrasound guidance, and always have a last kit ready for any eventful, any untoward incident happening, and practicing resuscitation of the patient who has suffered a loss by practicing it with simulation. And prevention also includes raising awareness and educating our non-anesthesiology colleagues about proper use of LAs and risks, and including management of LSD. Usually, when you give it in the post-op as a continuous infusion, many times especially I have had seen cases where people have injected the local anesthetic in bulk with the supraclavicular continuous catheters. Instead of 0.5 ml per kg, they give 2 ml, 3 ml. If proper instructions are not given, and even after the surgery, the chances of this complication are quite possible. So we must educate all our paramedical people or nursing people also about this problem. Now, what is the toxicity ratio, and what is the value of this for lignocaine and bupivacaine?
CVS by CNS ratio, sir.
CC by CNS, bupivacaine 3.
Bupivacaine 3 and
So
lignocaine.
the plasma concentration of LA drug needed to produce CNS toxicity to the plasma concentration needed to produce cardiac toxicity. So the value for lignocaine is 7. That means
7.1.
you require 7 times more value of lignocaine to produce cardiac toxicity after the CNS toxicity has acted, like your perioral numbness or seizure. You require 7 times more plasma concentration of lignocaine for producing the cardiac toxicity, whereas it is only 3 with bupivacaine, and it is about 5 with ropivacaine. So that is why ropivacaine is also considered more cardio-stable drug or cardio-safe drug. And this is the flow chart given in NISORA. This is the New York Association of Regional Anesthesia. So this is first support ventilation, left support stop seizure, and then lighted emulsion. And this is another flow chart for administration of local anesthetic emulsion according to the AAGAB guidance on yellow toxicity. So immediately you give 1.5 ml over 1 minute, and then start an interval of 15 ml per kg per hour. It is not per minute. And it is only 2.5 ml per kg per minute. And after 5 minutes, you repeat, recheck, and then depending upon the response, you continue with that. And that is the